thank you all very much for joining this next instalment of a lightning talk under Newcastle Health Innovation Partners. And we've got a real cracking double header for you today in the topic of rare diseases. My name's David Byrne. I'm the director of Newcastle Health Innovation Partners. I think you all know the Zoom protocol by now, just to double check that your lines are muted. I know most of you got cameras off, at least from where I'm sat, but obviously we've got a lot of people joining this call. Rare diseases obviously got a lot of pulling power. Or maybe it's the speakers, and so I can't see you all, and nor can they. So if you do have questions, please would you put them into the chat function, and we'll come around those at the end. As per normal, the idea is that we're going to go for about 15 minutes worth of presentation, and then 15 minutes worth of Q&A. So it's a great pleasure to introduce Vicky Headley, who's Rare Disease Policy Manager, and also Dave Jones, who you probably don't know which hat Dave's wearing, but it won't surprise you to know it's a rare disease hat rather than an education and training hat. Dave's a hepatologist by background in primary biliary cirrhosis, which got him into rare disease. And between himself, Vicky, and a cast of many, I wouldn't say thousands, but a cast of many excellent colleagues have put forward and had approved a Newcastle University Centre of Research Excellence in Rare Disease. And I suspect in their talk, they will be talking a little bit about that, as well as some broader aspects. So it's enough from me. Over to Dave and Vicky.
Thank you very much, Dave. And apologies, my cat is going to join in this, I think, at every available opportunity. So it's a real pleasure to do this. It's an area that we are enormously passionate about, and an area that Newcastle is really very, very good at. And so we've titled this, Why Should We Care About Rare Disease? And then subtitled it, Needs and Opportunities. And I think that summarizes. Ooh, next slide. We've thrown, okay, right. So, why rare diseases? Why do rare diseases of ill health? With about 7% of the population affected by one of them. So add everybody together, it's an important cause of problems. That's a group of people that did particularly badly during COVID as well. They also give you important insights into commoner diseases, some classic work around, say, diabetes that shed light on commoner diseases. It's a very high government priority area. This is because of very effective patient activism, which filters through to MPs' post bags, and also some of the needs to replace EU provision after Brexit. There is very substantial industry interest at the moment and investment in the UK, and that's something that Newcastle has benefited from enormously, and there is huge potential for the future. The UK is a very attractive partner because of the NHS and CRN model. It allows us to network nationally in a way that pretty much nobody else can do, which is obviously very important when diseases are by definition rare. But probably most of all, why rare disease in Newcastle is that we are very good at it, and we have been very good at it for a long period of time. And actually, we have done rare disease from long before the point at which the collective concept of rare disease came along. I always tell people I've worked in PBC and liver disease for 30 years, and I've worked in rare disease for 5 years. And it was only 5 years ago that the sense of it being a rare disease became important. In Newcastle, we work in multiple disease areas. We work across adult and pediatric, genetic and complex, common, rare and rare disease. And that's almost unique in the country. And what defines us is the translational aspect, converting science into practice, that makes a difference. We coordinated 3 of the European reference networks, which were networks of excellence across rare disease. We were the only centre coordinating more than one, and they were in our 3 cardinal areas of strength: neuromuscular disease, immunodeficiency and liver disease. And that's the bedrock on what we've built. And we also have real breadth into areas such as policy, which are pretty much unique. So we've done it for a long time, we do it across the board, and we do it in a way that makes a difference for patients. Next slide. So why a centre? Why rather than operating in individual disease areas, well, that's around the unmet need. Around 5% only of rare diseases currently have a therapy. And if you think about it, there are common challenges clinically around diagnosis, therapy innovation, trial design and delivery, and then clinical implementation, which cross across different rare disease boundaries. So the synergy potential is enormous, and expertise in one area, I think, can inform approaches in other areas. We can share experience about the challenges faced by patients to do with their lived experience. And because we've been very good in a number of disease areas, there is a potential to cross into other disease areas where the need is greater. And it truly is something where the whole is greater potentially than the sum of the parts. And so part of what we've done is to create opportunity, but also create visibility around our rare disease expertise, because perhaps we've not been as good at that in the past as we could have been. Next slide. So the sum of the parts is already considerable. The whole is potentially huge. And we do cover the complete spectrum from basic science to policy via all the steps in between. But critically, no one specialty area spans that complete range. Everyone can benefit from this. There is something in this for everybody. And there are some disease areas where there is enormous opportunity. We can all learn and we can all share experience. Next slide. And I just wanted to give one example. There are many, but this is just one. This is James Wason, a good colleague of a number of us, who is a professor of biostatistics in Newcastle. He's just been awarded an NIHR research professorship, hugely important. And the bedrock of what he does is advanced trial design to allow us to answer clinical questions in groups in whom we couldn't answer them before, par excellence in rare disease patients where patient numbers are limiting. His expertise ranges right across the spectrum of all the disease areas we operate in. And his NIHR research professorship is to take this into even further areas to be able to answer questions we've not done. And this is an example of the cross-cutting expertise and innovation that we can bring across the disease areas. Just one example of many, and James has kind of energized so many of us in this space. Next slide. So the ethos of the centre, this is very important to us, that this is to be enabling and to create opportunity for all. So this is for everybody in Newcastle. The entry qualification, if you like, is to be interested in rare disease in one way or another. So this is about for everybody. And we work with structures. We don't seek to create complicated structures or to challenge existing structures. This is to add value to people, most of all so that we can add value to patients, because they're at the heart of what we do, to use every opportunity to develop the partnership to deliver for patients. And as Dave mentioned at the beginning, I wear several hats, and my other hat is around developing the next generation of researchers and clinicians in this space. And so clearly we combine that passion with our passion for rare disease. And there is opportunity left, right and centre for people across the spectrum of clinical and research. And most of all, make this exciting and fun to be part of. This is an adventure that we're all embarked on. Next one. We have 4 components to what we do that go right the way across, from optimizing basic translational clinical research, the research component, through to applied research methodology, trials, health economics, understanding the value of interventions, then innovation in care delivery. None of this works unless it gets to patients, and it can't get to patients unless we change national policy, and we are working very effectively with Department of Health around innovation in rare disease policy, regulation and social science that Vicky will talk about a little bit more. And the more you get towards practice and policy, the more the contribution from Newcastle is truly unique. Next one. This is our range of areas of expertise, and in the iris of the eye, if you like, are the various different clinical areas. And I just include this to show the breadth of our experience and the breadth of the opportunity. Next one. And then the final slide from me, what are the opportunities? There are needs, I think, for our patients, but there is all real opportunity to make a difference. But that gives us a collective opportunity in Newcastle to be very strong indeed, to be unique actually in this space. So the level of industry interest, particularly post-Brexit, there has been a variable picture of industry investment in the UK post-Brexit, but the rare disease space is completely on fire in terms of industry interest, I think because the NHS's CRM model. There is a national framework for rare disease, which is under consultation at the moment to improve the deal for patients with rare disease. We're front and center in putting this into practice. We have some exciting opportunities which hopefully will emerge around an MRC center in rare disease and a catapult in cell and gene therapy arm in rare disease that we are working on. But there is the opportunity for fellowships and grants right the way across for the clinical spectrum, from basic science through to implementation into practice. And we are working widely and are happy to work with ever more colleagues in this space. So this is all about opportunity with patients at the focus. So Vicky, over to you.
Thank you very much, Dave. So Dave there in a real lightning presentation has talked a little bit about some of the needs and why we should care about rare diseases. And he's touched there upon some of the medical needs and the research needs, which obviously, if you think about 8,000 separate conditions, only 5% of them have any kind of dedicated treatment at all. There's major unmet need and major research need. But I'm just going to talk for the next 6 minutes or so about a different angle of our work, which is sometimes overlooked and is less obvious. And this is around the so-called hidden needs. So obviously there's a variety across these 8,000 diseases and no patient experience is the same. But the rarity of having a rare disease in itself poses all sorts of unique challenges in all aspects of daily life, in terms of not just the medical side, but also bridging that gap to the social care and support, education, employment. And this results in major inequalities for our patient population. This is an infographic from a study that EURORDIS, the big European rare disease organization, did a few years ago. It was on just over 3,000 patients with a mixture of diseases. We need more data, we need better data, bigger studies, but this was a really interesting piece of research when it came out, this survey, and it gave an idea of the scale of the challenges facing our populations, and the UK participated very actively in this. So I won't go through all of these, but just to give a snapshot, 7 in 10 patients and carers with a rare disease have to stop or reduce work. And that makes sense because an awful lot of rare diseases affect children. So very often the carers are the parents, one at least of whom has to basically often give up their work depending on the severity of the disease. 8 in 10 parents, carers and patients have difficulties either with practical tasks around the house in terms of dressing, washing, cleaning, but also with cognitive things. And one stat that's really interesting is that even just from this piece of research, and it's been supported with others, people are much more likely, if you're living with a rare disease, you're more likely, so this came up with 3 times more likely to suffer from depression and general unhappiness compared to the general population. So thankfully, mental health needs, I think, are at last getting the the publicity and the awareness that they need. And there's huge mental health issues affecting our patient population, which makes sense. If you think of the fact that, as I said at the beginning, so few of the conditions have any kind of medicine, any drug whatsoever. You're constantly battling against, nobody in the medical profession knows what you have. You have to explain yourself all the time. You feel very isolated. And we know, unfortunately, that COVID has made our rare disease population even more vulnerable. So there's lots of challenges. So we should care about all of our individual patients because we're nice people, but we should also care because actually together, with there being so many diseases, this comes down to 1 in 18 people, more or less. It's hard to get exact estimates, but around 1 in 18 people directly affected by a rare disease, with many more people around that in terms of families and carers. So if you do a quick back of envelope calculation to our population in the Northeast, you're looking at nearly 150,000 people directly affected. So what do we want to do in this space under the NHIP, the Newcastle Health Innovation Partners? Well, our first goal is actually just to raise awareness of rare disease needs amongst this group of broader stakeholders. I think across the university and the Newcastle Hospitals Trust, people have been working in this area for a long time, but I'd be really keen to see what the awareness and the interest is of rare diseases in our other NHIP partners, and to see how we can work together to identify and address some of these broader societal needs. Because, you know, at the heart of NHIP is reducing inequalities, inequities for people in our region. So I think this fits perfectly into that. We're going to do some events at the end of February around International Rare Disease Day to raise awareness of our work and what we're doing. And one of the things we're going to try to do, hopefully with Newcastle Council, is to get some of our bridges or our iconic buildings lit up in the Rare Disease Day colours. This has become a little bit of a trend in recent years. If we can get some resource, we would really like to go a bit deeper into gathering some data on that patient burden for our North East population. So even just reproducing the survey that I showed you earlier, those sorts of questions about daily challenges, it would be really nice to do some deeper, a bit of a deeper dive to really understand what patients' different lived experiences are and how much difference there is to that depending upon the type of condition that you have, whether it's genetic, whether it's life-limiting, whether it's acquired later in life. All of these things are important. And then lastly, we really want to focus, and we're in a great position with the group of actors that we have, to really identify some good practices that we already have actually across our region in some of our clinics and our centres around bridging that gap between really providing a holistic multidisciplinary clinical team, but also bringing in all the other actors that need to be there for patients. So the physios, genetic counsellors, specialist nurses, dietitians, and doing that in a way that makes it as easy as possible for patients to access all of that. We have some really good practices, recommendations, for instance, that I've worked on through various European projects over the years around exactly how you can provide that broader, more holistic, integrated approach. And actually real centres of expertise for rare diseases, which, as Dave explained, we really have for quite a number of conditions. We really are expert centres for those diseases. They need to do more, and they do more than just the purely medical. So they need to think about how they can actually go out into the community, how they can, for example, if a child's been diagnosed with a rare disease, how they can provide high quality information to that child's school. Because a simple thing like making, you know, reasonable adaptations would allow that child to stay in school. And that's massively meaningful for that child and their family. They don't have to go to a special school. Being able to navigate the health and social welfare systems, find out what adaptations you're entitled to. So all of these things, practical things like really making sure that we have as many specialised case managers and specialist nurses. This care coordinator role is something that actually at the UK policy level, through our new UK framework, that's a really strong topic for them, how we can provide more coordinated care. And that means coordinated medically, as I explained, with the different disciplines, but also getting that coordination and that bridge between the health sphere and the social sphere, because really, when patients have, you know, so much stacked against them, they have so many battles. I think as a society, we have to do everything we can. And often these are fairly, you know, they're not enormous high cost things. Do whatever we can to try to support that. So those are some of our ideas, what we would like to do under the Newcastle Health Innovation Partners. And we'd be really keen to hear your suggestions on how you could work with us, how we can optimize what we're doing. So I'll stop sharing there.
Thank you, Vicky. That's great. Thanks, Dave. Yeah, that's great. So as Anne's just saying, don't be shy, but I do have a couple of questions actually that have come in separately during that. And that's really, really helpful and informative actually. So a couple of points. Firstly, maybe to you, Vicky, particularly, how much does a postcode lottery affect rare disease care?
Very much. It's really hard to get really good study data, but there is some. But anecdotally, for sure, you know, clinicians know that actually patients who are lucky enough to live near the top expert centres, so who can access, you know, the experts in our centre, their outcomes are better because there's better awareness about, you know, not about curing the conditions, because often that's not possible, but about what you can do to prevent things from getting worse. People know what the top level standards of care are. And actually, unfortunately, you still quite often hear about patients moving within a country or moving from country to country to actually be nearer a centre of expertise after they get a diagnosis. when they get a diagnosis.
Yeah, thanks, Vicky.
Can I just say with that, I mean, we're doing an audit in rare liver disease, and there are three kind of levels of data on that. There are the expert centres with really good outcomes. There are the participating centres who take part in the audit. They're typically less good. And there are people who aren't answering the emails. And I think that sums it up. The worry is actually the centres who just don't answer the emails, because heaven knows what their provision is. I think there is a major opportunity post-COVID. I think we got familiar with care delivery at a distance. And actually, a lot of our patients really like the blended approach. The sort of coming once a year to the clinic, they can understand, but then the opportunity to get management at a distance. And that does change the reach of expert services like ours, because all of a sudden it's not by sort of local transport issues. And this is at the heart of the framework for rare disease coming out of DHSC for consultation, is that there must be no geographical variations. And actually the question then is, can we in Newcastle get involved in the management of somebody in Truro if that's what the patient wants, using distance management? And I think the disruption in that there's been negative disruption with COVID, but there's also been some positive disruption to the system that I think we can capitalize on. No,
that's interesting. Very good. I mean, and yes, and as you're implicit in what you're saying there, David, the idea of remote data capture, right, there's stuff starting to really fly in here. So Mary Anderson, really good that you're on this call, Mary. Thank you. And actually, that links into one of the other questions that I was going to ask that have come in. We've all seen about last week, perhaps, the 100,000 Genome Project and what a difference it had made in terms of making a diagnosis to people with rare diseases. So, I mean, I think we also understand that maybe genetics won't give all of the answers, but Mary's questionnaire is, particularly regarding to Newcastle, what's the link up planned with the NIHR Bioresource and collaborative work with, for example, NeuricPath and RareCan? Is there going to be a sort of link across there, Dave and Vicky?
Yes, is the short answer. So those discussions are ongoing, and the MRC in particular is looking at the best way to develop its strategy moving forward, and I'm involved in that group, and that includes not reinventing the wheel. So if there are initiatives around networking in rare disease already, then don't reinvent them. There is nothing to be gained from that. So we don't need more bioresources. We need to utilize the ones that are there much better. So that work is now ongoing. And a lot of this is post-ERN. And, you know, we were at the heart of all of that. We were real pioneers in it, but there is a realization that we need to do something different now. We've left the EU, we've left the ERNs, and actually we can learn from what the ERNs did and do it better. And that work is now ongoing. And I think
sorry, Dave, I'm going to stop you because there's loads of questions coming in and we've only got a few minutes. Wyatt Hugh asked a question. Wyatt, it's really great you're on the call. Welcome to Newcastle. And you, Professor of Structural Biology from Oxford, really keen to work in the rare disease space. So he's looking forward to working with you in the new core and the initiative generally. But his point is, you've mentioned opportunity space in industry, Dave and Vicky. Conscious it's broad, but do we have any views on how to kickstart efforts in the direction, any particular companies or disease areas to focus, or any specific types of research? Wyatt, I think Dave must have paid you off to ask that question, but yeah, go on, Dave. Keep it.
Yeah, I think it's bi-directional. I think we capitalize on existing contacts and opportunities, which is a lot of what we do, but we also go the other way, which is the areas of unmet need. And we've got some industrial advice coming in about how to do that. So we both target areas we're strong in already and have strong industry links, but we also target some areas where it is needs driven, where the existence of an opportunity will in turn attract industry. So we're going to do it from two directions.
Fantastic, super. And then Dr. Adetona's come in. Interesting, pithy question right to the heart of it. How do you want to put the data of rare diseases together? Now there's a challenge. Oh,
wow. Vicky, do you want to answer that? No.
One of the good things there is that across our group, we've got experience of, for instance, setting up registries, which are really important for rare diseases, and of running registries, but we're also involved in lots of international initiatives around data science and around things like fair data principles, principles to make data more interoperable. So we're thinking more about that sort of federated ecosystem. A really interesting area will be how we make better use of real world data, particularly things like electronic health records. So it's great that we have a lot of the data expertise in Newcastle embedded in the new core. We're going to need that. But yeah, absolutely. Data is central to so many different topics under the rare disease heading. Lots of data and stats. Yeah,
so virtual trials where you can run national trials at a single centre, hugely attractive. But the important thing is don't make one of the mistakes that the ERN's made, which is to have a one-size-fits-all top-down approach to data, which actually ended up being a negative. The data sets needed will look very different in different areas. So my short answer is to talk to people who are far better at data than I am to get the right answers. But networking and virtual trials is a major deliverable of this.
So I don't know, Dr. Ida-Turner, whether you have some interest in this space or some ideas, but I'm sure offline, yes.
Yes, please.
Yeah, that would be absolutely following up on both. Mary's come in with a really helpful comment there about accessing existing bioresources and Joint Research Office in Newcastle. Very happy to work with you on all of this.
Yes.
So that's great, and I know you do some great work in that space. So thank you. That's absolutely excellent. I mean, Dave, I think the other thing, and Vicky, because you've both been scarred/informed by the European experience. Dave, I always remember when you were writing the document, there are some very fundamental differences which you partly alluded to, but just for the audience in the last couple of minutes, would be probably just worth drawing from your experience to say, UK Rare Disease Network, which is the goal, versus ERN. What are the learnings that you will amend or / incorporate in the UK model compared to that which was in ERN?
Right, I'll give you my view first, and then I'll be, I think, fascinated by Vicky's view on it as well. So the big mistakes with the ERNs is they were top down rather than bottom up. So they had a single model for all diseases of all age groups across all of Europe, and ultimately that didn't work because the nuances are very different, and it also never managed to deal with the issue of cross-boundary money flow. So if you were a patient in one European nation being managed in another, money flow never sorted out. Now, in the UK, because we have a single NHS model, that should be straightforward, although it's something we've always struggled with in the past, but notionally, a single healthcare system should be easier, and also absolutely hardwired into the national thinking in the UK is to make this bottom up. So start with what's needed in the disease areas and take it from there. And then the other fundamental difference is, for whatever reason, the ERN model was very anti-industry involvement. And actually, I think in the UK, it's the major opportunity. And I certainly, with the patient groups I work with, they know full well where new diagnostics and new treatments come from. And so they want us to work with industry. And I think that's where the UK has a huge opportunity. I think that's why all the money is flowing into the UK at the moment. I'd be fascinated by Vicky's thoughts.
Yeah, Vicky, anything on top of that?
I'd agree with the industry. I think one of the strengths of ERNs is the concept that actually by grouping the conditions and thinking about which diseases fit where, you get to that, no rare disease without a home sort of concept. And that's important. And we could learn a lot from that, I think, in the UK by actually doing that, not back to basics, because the people working in the disease areas know who they are and know each other. But there's no single place you can go where you can find all the rare renal, the real expert centres across the UK easily mapped out. We have the highly specialised service system, and that's great if your condition falls under one of those, but some of them are very specific. They're excellent, they're very quality assured, but it means that approach, you're going to miss out so much. So we're hoping, as Dave said, to really work more and more with DHSC and with the actors putting into place the UK's new framework for rare diseases, to try to do a little bit of a recreation of the ERNs at UK level, but as Dave said, with the best bits in, and letting us take some of the opportunities that weren't there before.
That's brilliant. Thank you both very much. Well, Vicky, big thanks to you, because I know you've joined us remotely from Europe, actually, and your line held up beautifully. Dave, I know you've joined us from the wilds of Northumberland, from a home that is got the plague, so that's much appreciated. Just to draw your attention to Anne Fitchett's note in the chat line there, because there is a chat box, because there is an event on advanced therapies hosted by John Isaacs on the 26th of November, which is a full afternoon. So that's a really interesting program as well. Thanks to you all. I think we got up to mid-70s joining us at our peak on this lightning talk, which for half an hour in the middle of the day is quite some going. So thank you all so much for your time. I hope you got a lot out of that. I know I did. And as I say, thanks again to Dave and to Vicky for their input. Thanks a lot, and bye everyone.